You're on duty in the ICU. The nurse says, "Doctor, this patient's test shows a sodium of 118. What to do?" And you ask yourself, what to do? Do I treat? Do I wait for it to resolve? What test should I order? If you're afraid of sodium, this video is for you. By the end of the video, you will figure out how to stabilize sodium, how to evaluate among the causes, how to remember the steps of evaluation, and how to correct without causing osmotic demyelination. And after that, you will never panic at a sodium of 118 again. No excessive complicated theory, only what you will apply on patients using a logical approach. First of all, hyponatremia is not about sodium. It is about excess water in relation to sodium. See, concentration of sodium is what we measure, and it equals the total amount of sodium divided by total amount of water. So when you were asked what to do, you have to ask how urgent it is. Is the hyponatremia acute and symptomatic? And the symptoms that we need to worry about are seizures, confusion, coma. If these are present, evaluation can take a backseat for now, and we need to stabilize first. Not treat completely, only stabilize. And for that, you will give 3% saline over 10 minutes, and our goal is to only increase by 4 to 6 millicurrent and not try to normalize. And we will keep monitoring the sodium. And if it is not symptomatic, you will then ask the next question. If this hyponatremia is even real, what do I mean by that? Let's understand this. See, all the problems that sodium causes is because of its role in maintaining osmolality. It is the low osmolality and not the low sodium number that is causing the symptoms. See, a majority of osmoles are sodium and other ions. Then there's glucose, urea, and other osmoles. To calculate the serum osmolality, we use the formula 2 times sodium. Why 2 times? Because sodium is the major positive ion, we multiply by 2 to account for the accompanying negative ions like chloride and bicarbonate. Hence 2 times sodium. And to that, we add the osmolarity contributed by glucose and by urea, and any other osmoles if any. Now let's take a look at this graph and it will help us understand better. It shows a normal osmolarity is predominantly contributed by sodium. And when falling of sodium is the main pathology, the total osmolarity also falls. But if sodium falls due to increase in other osmoles like glucose or urea, or osmoles such as mannitol, we'll see that there is low sodium but the serum osmolarity will be normal or even higher. What it essentially means is that if low sodium is not accompanied by low osmolarity, we need not worry about the sodium at all. We need to worry about what's causing it. So when you ask, is the hyponatremia real? What you mean to ask is, get me a serum osmolarity. So you can check whether other osmoles are the culprit, in which case, correction of the culprit osmole will normalize sodium on its own. Now, if it's hypotonic, then it requires the evaluation that we'll discuss. If it's isotonic, it's pseudohyponatremia, and it can be caused by excessive lipids or proteins in the serum. How? Let's discuss that in the comments. Drop down what you think is the reason this can happen. And if it is hypertonic, it can be glucose or other osmotic agents like mannitol. Now one interesting thing is, for every 100 mg per deciliter rise in glucose, sodium falls by 2. So you can actually correct for that. It doesn't sound like much, but it can cause significant lowering in case of decay when glucose is extremely high. So now we know it's hypotonic. Now what? Now this hypotonic hyponatremia can occur in 3 ways. See, if this is normal water and salt amount, you can have either excess water in comparison to salt that can lead to hyponatremia, or normal water but less salt, or less water but even lesser salt. We call this hypervolemic, this euvolemic, and this hypovolemic. Hence our next question once we have the osmolarity is, what's the volume? Hypervolemia is sometimes obvious with signs such as edema, ascites, and is usually seen in patients of heart failure, liver disease, or chronic kidney disease. Hypovolemia, on the other hand, will have signs such as orthostatic hypotension and dry mucosa, and can occur with fluid loss from the GI tract or from the kidneys. The third is euvolemia, where we don't have any obvious overload or any obvious dehydration signs. And this is where most of the real confusion lies. See, management of hypervolemia is fluid restriction, and of hypovolemia is fluid replenishment. Euvolemia will need workup, specifically to rule out hypothyroidism and Addison. Only then we can go on to diagnose SIADH. Now, SIADH in itself is a topic worthy of discussion, and we'll talk about it in our next video. Let's understand the hormone ADH first. Your blood is flowing through the vessels. It is sensed by osmoreceptors, which then cause the posterior pituitary to secrete ADH. ADH, as the name suggests, conserves water. So when high serum osmolarity is sensed, ADH is needed, and when low is sensed, ADH is not needed. Now, does that mean all causes of true hyponatremia will have suppressed ADH? No. Because osmolality is not the only stimulus for ADH. There are other non-osmotic stimuli such as low effective arterial blood volume, hypotension, nausea, vomiting, pain, or some drugs, and also hormonal deficiency. Now, what happens when there's a conflict of stimuli? For example, a patient has low osmolality and also has hypovolemia. Here, the volume status would want to raise ADH, but the low osmolality would want to suppress ADH. Now, what happens here is volume wins, as the body has to prioritize quantity of serum over quality, because circulation first, then concentration. But other than this, osmolality is one of the strongest influencers of ADH. But how do we know that ADH is high or low? We cannot measure the levels of ADH, as its half-life is only about 10 minutes. So we measure the effect of ADH by measuring the urine osmolality. See, kidneys have a remarkable concentrating and diluting capacity, so much so that the urine osmolality can range from 50 to 1200. But this is the capacity range, and this range is not valid for all clinical contexts. See, if this glass of water shows your serum, and this drop shows the urine that is formed, when your serum lightens up, that is, its osmolality gets lowered, the urine should also lighten up. That is, urine should also have a low osmolality to compensate for it. Hence, with low serum osmoles, even an osmolality of 100 is high because we expect the kidneys to maximally dilute the urine and to go as low as 50. So when you order the test of serum osmolality, don't look at the reference ranges given by the lab. Ask yourself if this urine osmolality is normal for this patient. In other words, you'll ask yourself, is ADH on when we want it to be off? Now, ADH will be off when urine osmoles are less than 100, and that means the kidneys are doing their job. In these cases, if we find low sodium, that can be because of either consuming more water, which is seen in primary polydipsia, or consuming very, very low amount of salt, as in beer potomania. But if ADH is on, we'll ask if this is appropriate. See, in cases of hypovolemia or decreased effective arterial blood volume because of third spacing, ADH activation is appropriate, because here the non-osmotic stimuli is taking over. But high ADH in SIADH, diuretic use, hypothyroidism and Addison is inappropriate. Now, when hypovolemia acts as a trigger for ADH release, it also acts as a trigger for RAAS activation. Now we know that RAAS will ultimately lead to sodium retention by the aldosterone. When sodium will be retained by the kidneys, it will not appear in the urine. Hence, urine sodium will fall below 30. Which brings to our next question that we need to ask, is RAAS on? Now, if we are asking this question in the context of hypovolemia, we get that RAAS is off. That means we are losing fluid and salt from the kidneys, which can occur in either diuretic use or mineralocorticoid deficiency, salt losing nephropathy, or cerebral salt wasting. That means the loss of volume is from the kidneys itself. But when RAAS is active, that means the loss is somewhere else and the kidneys are trying their best to save the sodium and water. For this, the causes are vomiting, diarrhea, or third spacing. Now, when we ask the same question in a patient with excessive volume, if RAAS is active or not, and if we find that this urine sodium is more than 30, that is, RAAS is not active, it means the kidney is losing sodium, that means the kidney is the cause. And in that case, with hypervolemia, kidney being the cause, we'll think of renal failure. And if the RAAS is active, that means kidney is not the cause, and it can happen in cirrhosis, cardiac failure, and even in nephrotic syndrome. In all these cases, fluid restriction is usually the only treatment that is required for sodium. Now, you'll fail to apply any of this in your wards if you don't know how to correct sodium. You should only correct 6 to 8 milliequivalent per liter of sodium in 24 hours, and less than 18 in 48 hours. You again ask yourself, how will I know how much sodium will be corrected with fluids? For this, Adrogue and Madias gave an equation. Hang on to your seats, we'll do some math. So the change in serum sodium with every liter of fluid will be the difference in the sodium of the fluid and the serum sodium divided by total body water plus 1. So if serum sodium is 115 and we're using 3% saline, which has a sodium of 513, we'll divide the difference of 398 by total body water, that will be 36 for a 60 kg man, plus 1, and that will be roughly 10 to 11 milliequivalent per liter. So we don't give a liter of 3% NS, we only give 100 ml at a time. So we'll be raising sodium by only 1 or 1.1. And that's why boluses are controlled, but you still need to monitor very cautiously. Now before you go further, just a couple of things. 1 liter of normal saline contains 154 milliequivalent of sodium. A 0.45% or half normal saline contains 77 milliequivalent of sodium, and a 3% saline contains 513. This is something you should know, and this fact will help you calculate. Now you also need to know the calculation of total sodium deficit, that is, total body water and difference between the desired and current sodium. So in a 60 kg man, the total body water comes out to be 36 liters, and the difference between the desired and target sodium is, let's say, 6. So the deficit becomes 216. This gives you a rough idea of what fluids to be used and how much. But you should still correct with monitoring. Now you might ask, we have questions to predict the rate of correction, then why to monitor? Because all the formula that we have are only estimates. Also, when you restore volume, ADH shuts off. hence sodium may be corrected on its own. Hence there is a risk of overcorrection, and hence monitoring is very, very necessary. The highest risk of overcorrection and hence osmotic demyelination is carried by a subgroup of patients with severe chronic hyponatremia who are likely malnourished, who are alcoholic, or have liver disease. Now to sum it up, here's a list of questions that should always come to your mind when you see a low sodium and what you should do about it. Save this, it will help you a lot. First, is it symptomatic? If yes, go with 3%. Second, is it true hyponatremia? Serum osmolality will help you. Third, what is the volume status? Assess clinically. Fourth, is ADH on? Check urine osmolality. Fifth, is RAAS on? Check urine sodium. Sixth, is hypothyroidism and Addison ruled out? And last and most important, am I correcting it at less than 8 in 24 hours if there is no emergency? Use the Adrogue Madias equation to help, but always monitor to prevent overcorrection. And that was it. In the next video, I'll help you understand SIADH. If you have any doubts regarding managing hyponatremia or any suggestions on what topics I should cover next, feel free to drop them in the comments. I'll see you in the next video.